This week on the BackTable podcast.
Forcing yourself to sit with the discomfort of being silent and allowing what you just said to kind of permeate can have a really strong effect. And sometimes let the patient take charge of the conversation, telling you more what their head is at. Maybe they are not in a space where they can even begin to understand the medical implications of the treatments you're about to offer because they're thinking about their spouse or their daughter or whatever it is that they have going on in their life, So giving them space to share that with you can guide things so much more efficiently sometimes too.
Hey everyone, it's Gina and I. We're back and really excited for another episode of our BackTable Education series. Today we have two guests who we're really excited to have a conversation with. I'm going to let each of them introduce themselves, but very excited for the different perspectives they bring. So Ashwin, maybe we'll start with you. Can you introduce yourself and tell us a little bit about your background and why we have you on a show where we're talking about urology and palliative care?
Yeah, sure. Thanks, Lindsay, for having me. Really excited to be here. My name is Ashwin Kotwal. I'm a geriatrician and palliative care physician in the Division of Geriatrics at UCSF. So I did my fellowship training in both geriatrics and palliative care, and now I attend on the inpatient and outpatient palliative care services at the San Francisco VA. I think a big reason why I'm here is just to think about opportunities for learning about palliative care and how that might impact the care of people seen in the urology clinics or when people are in the hospital, and also to brainstorm ways of improving access and also some of the skills that urologists might have throughout their training or even further on in their career.
Awesome. And I know our own trainees at UCSF have benefited from you greatly. So it's the power of collaboration. Pauline, welcome. Why don't you tell us a little bit about yourself?
Thanks so much for having me. And thanks for doing a podcast on this topic. I got really excited when I saw that you guys were doing this. So I'm Pauline Filippou. I'm a urologic oncologist with the Permanente Medical Group at Kaiser in Northern California. And I'm also a affiliated assistant professor with the Stanford Department of Urology. And in my fellowship, I actually did kind of a palliative care, not so much fellowship, but like master's program to be able to deliver palliative care through my practice. So gained skills that way, and then focused a lot of my research during fellowship on the integration of palliative care within urology. So super excited to be having this conversation with you guys.
It's great. We're very fortunate to have both of your expertise on this podcast, and I think we should just kick it off. We'll start with you, Ashwin. Tell us a little bit about what palliative care is. What do we mean when we're talking about palliative care? What are some differences and similarities related to hospice care? I think that there are a lot of misconceptions around this.
Yeah, great question, Gina. And this is something that comes up all the time. I think both for clinicians as well as the patients and family members that we see, because palliative care is a relatively new specialty and is being expanded in many different hospital settings. So I really like some of the definitions that the Center to Advance Palliative Care uses. So it's capc.org for people who want to check it out. But basically, there's a couple of different components. The first is it's specialized care for people who are living with a serious illness. And the goal is to improve quality of life, both for the patient as well as for the family. It's also important to know that palliative care is an interdisciplinary specialty. So it's provided by a team of physicians, nurses, social workers, chaplains, psychologists, and other specialists who might work all together. A key thing to be aware of with palliative care is it's appropriate for people at any age and at any stage of their serious illness. So it can be provided alongside curative treatment. And it's really based off of need and, thinking about symptoms, need for complex treatment decisions, and not based off of prognosis.
Yeah, I think that's so helpful. And Pauline, I'd love to bring you in here because I think oftentimes when we hear the word as urologist, palliative care, we think of something that's like end of life. And, when I hear Ashwin talk about, symptoms and quality of life, these are things that we're dealing with day to day in a lot of our patients who are not necessarily at the end of their life. So how do you think about incorporating this, and how should trainees and urologists think about incorporating this into their own practice?
Yeah, great question. So I think the key of what Ashwin's awesome definition was that it can be incorporated at any stage of any serious illness. So prognosis, chronicity of the illness, it doesn't impact when palliative care can be provided because it's given alongside curative treatment. There's no need to stop giving the curative treatment that the patients and the families want if you're seeing a palliative care clinician. And it's a very common misconception about or among family members and patients and clinicians, really, that palliative care is equivalent to hospice, which it means that you do have to forego curative treatment in order to enroll in hospice. So when I bring it up to patients and when I talk to trainees about it, I tell them to address the misconception. I tell them to bring up the difference, that it's not hospice, that it can be given at any stage of an illness. And sometimes that can kind of mitigate these misunderstandings of what palliative care is.
And do you name it? Like, do you call it, or do you tell people to call it palliative care? Do you not name it because you're worried about the misconceptions? Like, how do you kind of tell trainees how to approach that?
Yeah, I think there's, and Ashwin, you can speak to this better, but there's been a movement kind of to say, well, should we be renaming it because there are these misconceptions? I kind of call it what it is and then just educate on the back end because I think, the specialty is here to stay and it's so valuable that calling it something else may just confuse the picture even more. So instead, using education or just kind of talking about the misconceptions can kind of help parse that out.
Yeah, and I agree. Sometimes there's some fear around involving palliative care because, people feel like making a referral there is giving up on a patient or giving up on, the potential treatment options. And so, I have seen cases where the specialty or the service is renamed. For example, at UCSF, we've used the term symptom management service. I've seen palliative care involved in cardiology where it's called supportive cardiology. So it's I think the most important thing is to get people seen when they have that need and reducing those barriers to referrals.
Yeah, amazing how kind of just titling something differently can get people to mentally reset and be open to these definitions, which are so important. Pauline, so we'd love your reflections on the AUA white paper as it relates to urology and palliative care. What do you believe are the most critical components of that are important for our urologists to implement?
Yeah, so the AUA white paper was kind of the summary or like compilation of proceedings from the Quality Improvement Summit that we did back in technically 2022. It was supposed to be from like 2021 and then COVID happened. But anyway, the Quality Improvement Summit through the AUA was on palliative care integration in urology. And the white paper is a really great summary of both kind of what we talked about through the different webinars and then the in-person meeting that we did, and kind of outlined how the people who participated in that summit see palliative care integration kind of being fostered in urology. I think one of the main takeaways was this kind of like gradation of palliative care involvement. So calling on urologists to integrate some primary palliative care within their practice. And what I mean by that is just palliative care skills that are delivered by a non-palliative care clinician. So basic, communication strategies to deliver bad news, talking about prognosis in kind of certain ways, and then assessing for symptoms and stressors of serious illness. And then when the kind of skill level or where the need exceeds what the urologist is comfortable with, then referring to, a palliative care clinician to kind of help and take it from there, so to speak, because there is a huge palliative care clinician shortage. And so seeing is how we ourselves can kind of take up the reins in terms of referral and also integrating some of these skills within our practice. It's a great paper. It's got lots of resources too about where you can get skill training and how you can learn more. So really recommend checking it out.
Yeah, I think, that brings up I think probably a role for more integration in these challenging patients where you may know how to counsel somebody on the kind of one piece of your urologic, issue that they have, but you may not understand or know how that fits in with the rest of their picture. I think at the VA, actually, we see a lot of this where people are really sick and you're really trying to optimize quality of life. And you're wondering, well, how does my piece as a urologist fit into that? And I think that's where we've been really successful, partnering with our palliative care partners and having them help us have these discussions. And it really takes somebody, and Ashwin, I'd loved your perspective on this, but you have to actually learn a lot about what we're talking to patients about, right? You have to understand what surgery are we talking about? What the prognosis do they have in order to have their whole, not to mention all their other comorbidities and other things they're dealing with and what their goals are, right? So talk a little bit about what that process is like when you partner with a urologist, for example.
Yeah, great question. I think most palliative care clinicians try not to have goals of care conversations about what to expect from surgery, on their own, because that's exactly right. We're not specialists trained in advanced urologic surgeries, but we can help facilitate those conversations and try to think about the big picture. So I think where we've been most successful in some of these partnerships is when we have open lines of communication, where we can just message one another and run different cases by one another in terms of what's most appropriate here. Would it be helpful if, we can get your team involved here? That's often something that happens on the inpatient side where people will consult palliative care with not the clearest question, and that's completely okay. And most palliative care teams really want to think through the many different ways that we might be able to support urology teams in kind of thinking through these complex scenarios. The other thing I've noticed that can be helpful is when we have joint visits. So maybe palliative care might meet with a mutual patient to get to know them first, learn about their values, think about their prognosis from a big picture standpoint. And then there's a joint visit where palliative care team and, urology team are in the same room or even over a video visit to talk through some of the important decisions, what to expect, how to best align those options with their values. So I think, having clear, open lines of communication is probably the most important thing here.
I love that. I think the communication between the two teams is so important because often there's just a referral placed or a quick one-liner, consult this. And there's so much that either if the urologist saw the patient first, family dynamics that they picked up on or issues that they're most concerned about, like why they don't know that the goals of care of the patient are aligned with what you're going to deliver. Having that conversation with the palliative care clinician before sending them or before they meet with them can sometimes really help focus the conversation as to how you kind of want it to play out a little bit. So I think the more communication, the better. And I love the idea of a joint visit. I haven't been able to structure that into my practice yet, but I think that's a great idea.
I know there was some talk about, even thinking about multidisciplinary conferences, for example, where you could present, complex patients and really get different perspectives. You get the surgery perspective, you get the geriatrics, palliative perspective, even other, perspectives, nutrition, physical therapy, other things that might be important to patients as they're facing big choices. Is that something, have either of you seen that model actually put in place and work?
Where I work, we're fortunate enough to have this board called the Senior Surgical Service Board. So every patient over 75 who's getting a major abdominal surgery goes through this multidisciplinary review. The anesthesiologist, the primary care physician, a cardiologist, but a palliative care clinician is part of that review. And then the surgeon and all the people who talk to the patient meet before the surgery to make sure not only that they're optimized from a medical perspective, but that the goals of care of the patient are kind of in line with what the surgery is going to be accomplishing. And it's awesome. I have seen so many outcome changes happen as a result of it, both for elective and non-elective surgeries. And I think it's something that really fosters a collaboration that maybe otherwise wouldn't be there as much.
That's super cool to hear about. I feel like we have a maybe an idea for something to implement at San Francisco VA. What I've also seen is that it's helpful when palliative care is involved earlier, especially before surgeries, just to sometimes get people introduced to the concept and know that palliative care is going to be part of the team to help with symptoms, to help think through decisions, to think through the long term. So I think if it's possible to happen in a broader multidisciplinary conference, that is awesome. Ways to get palliative care involved can also be, quick or light touches earlier in that illness trajectory.
Well, and I think just to put like specific examples even to it, I mean, even thinking about like, well, what are expectations around going home after a big surgery? Where do you go? Who's going to be at home? How do you put those resources in place? These are things that, we think about so much getting the patient to surgery. I think we probably don't focus enough on what happens afterwards. And it doesn't even have to be a surgery. It can just be, I think general treatment and quality of life and what people's goals are and how to put things in place in their life to help those goals kind of come to fruition.
Yeah, I think that this is really important. And I think since this podcast is geared towards trainees, maybe not working in an environment where there's such a rich infrastructure, these conferences, or have access to experts, what would you recommend for trainees or even residency program leadership that are looking to foster more of a curriculum to teach their residents about effective communication and symptom management and some of the key principles you've brought up? We'll start with maybe Pauline and then go to Ashwin.
It's tricky. I think, modeling, obviously, the interaction as a, residency program director or attending, talking about when you would consider getting palliative care involved or why and how. I think bringing palliative care clinicians to grand rounds to speak about, their involvement with patients or what they can offer at that institution that they're at if they have palliative care as part of it. I think if not, to put a plug for the core curriculum, there's actually a core curriculum piece on the AUA website of palliative care, and it goes through, definitions and uses, but also there's a skill building section that talks about how to deliver bad news, obviously very peripherally kind of summary of how to do it, and then links to resources where you can learn more. I think, unfortunately, there's a little bit of an onus on us to train ourselves at this point, especially clinicians who are out or people who don't have palliative care built into their education training program yet. There's really great modules and courses that you can take to help augment these skills. So I think probably starting there. And
I think, at UCSF as a program director, I've actually, the reason that I, thought of Ashwin for this podcast was that he's actually come to talk to our residents. We schedule a 1 hour of didactics a year on goals of care, palliative care, symptom management, something in that sphere. And we've had Ashwin and others come to talk to our residents about it. So Ashwin, what's that like? Do you do that with other departments? Is that something that you think that works as a model of kind of going in and talking to trainees in another discipline, like coming to, urology residents and talking to them?
Yeah, I think it's a really nice way to introduce the concepts of palliative care, go over these definitions, think through when to refer to palliative care, and also provide a little bit of a few frameworks for how to have some of those difficult conversations. And I know that in my experiences with the UCSF urology residency, first of all, I found that people are really enthusiastic. They're really excited to learn. So it's a fun part of, my day to interact with residents and trainees. There's a huge need. I mean, we usually start our discussions just asking about difficult situations or, times when difficult conversations have come up. And what I'm usually struck with is just how common it is. Nearly every day there's a difficult conversation. I think last time we were talking about PSA screening and, just routine nature of that for us can actually be pretty devastating for patients and family members to think through, a high PSA, number and what that means in terms of biopsy and how to make these decisions around next steps. Many trainees, residents, people further along in their career, they're not given that much time to have these conversations. So it's important to think through how to have them most effectively. So I think there's a huge need. And to build on some of what Pauline just mentioned in terms of resources, yes, I think reaching out to your local palliative care team to get in a nice couple lectures would be good. Looking towards resources online. So Center to Advance Palliative Care has a lot of partnerships with universities across the nation and has some great modules around communication as well as symptom management. And then another nice resource is Vital Talk. Vital Talk is a program that helps to build communication practices for people across specialties through kind of an intensive training session. And that's something I actually did as a palliative care fellow and can be helpful at any stage of people's training.
And when you go to talk to residents, for example, I'd love to hear some of the kind of tips and tricks that you tell them about, we don't really train our residents in how to have these difficult conversations or how to assess someone's goals or kind of thinking about the bigger picture. So what are your pearls, that you give people?
Yeah, there are a lot of pearls. I think one of the key things that we try to share with people just getting started with serious illness communication is that people feel inherently uncomfortable with these topics. They're really hard conversations. And you don't start off being very good at these conversations often. It's something that's a skill that you have to practice over time. And you actually have to lean into some of that discomfort and kind of put yourself in those situations where you're practicing. The second is that there are key principles around most serious illness conversations that can be helpful. So, for example, these are highly emotional conversations. And when people are processing the emotion of just receiving bad news or something that may have been unexpected for them, it requires actually sitting with that emotion and helping people process it before you move on to thinking about the next steps. I really like one of the studies actually published by one of my mentors in medical school, Dr. William Dale. He's at City of Hope now. But he did a study where he looked at men who were recently diagnosed with prostate cancer and how they decide on proceeding with watchful waiting versus prostatectomy. And what he found was that even when you control for all the clinical characteristics and the clinician characteristics, one of the driving factors for whether people pursued prostatectomy versus watchful waiting was actually their anxiety level. And so people much preferred prostatectomy, even when it was not totally necessary, if they were highly anxious. So just thinking about that, these emotions really drive people's decisions. And so a key component of almost every communication framework is providing a lot of time to help people think through and process some of that emotion before you jump to those next steps.
Pauline, I'd love maybe you have an example or something of where have you, for our trainees who are listening and thinking about how to integrate this more, do you have the patient example where you feel like this kind of approach has been really helpful?
Definitely. Ashwin, I think also just piggybacking on what you were saying, one of the things I hear from urologists a lot who are hesitant to kind of integrate or train in a deeper palliative care kind of delivery is that they don't have the time, right? That our clinic visits are already filled to the brim with management and, questions and things we have to address. And it's like one more thing. But, I'm curious to hear if you have any recommendations for people about how to, carve out that time because it is so important. And like you said, it's the main driver in a lot of these kind of urologic decisions. Sorry, that was off topic to what you said, Lindsay. But
I agree. These conversations take time. And it is hard to sometimes fathom, fitting in a deep emotional conversation when you're trying to get a lot of things in place. But sometimes processing emotion can actually make the conversation more effective. And so it's well worth it. And it doesn't require tons of time. One of the frameworks we use for processing emotion is the NURSE framework, which is drawn from Vital Talk. So NURSE stands for naming, understanding, respecting, supporting, and exploring. So these are all ways of showing someone that you're listening hearing the emotional response that they've just had without trying to jump to fix the emotion. Like, oh, you shouldn't feel sad about this. We can do this, right? No. Instead, you stop and say, this must be so hard to hear, showing that you are understanding the emotional experience that they're going to, or that this is frustrating, so that would be something. Let's say someone has gone back and forth between, many different treatment experiences. So just saying that, simply putting, a couple minutes to name or help process an emotion can help people just have enough time to move to the next steps. I'll also often ask a lot of questions, ask permission a lot, if that makes sense. So, I just shared some really hard news. What questions do you have? Or would it be okay if we talk about the next steps? Asking permission to kind of move from topic to topic is something that can help people just kind of compartmentalize everything that's going on and figure out the right ways, that they can, process the next steps. So all of this to say, these are complicated topics that we're often talking through patients with very little knowledge around these medical situations. And so the more we can provide them space to think through this, the better.
I think silence, too, is something rarely employed. It's really hard for us to be quiet, right? Like, I think some study looked at how often doctors interrupt patients, and it was like every 11 seconds or something. Forcing yourself to sit with the discomfort of being silent and allowing what you just said to kind of permeate can have a really strong effect, and sometimes let the patient take charge of the conversation, telling you more what their head is at. Maybe they are not in a space where they can even begin to understand the medical implications of the treatments you're about to offer because they're thinking about their spouse or their daughter or whatever it is that they have going on in their life, So giving them space to share that with you can guide things so much more efficiently sometimes too.
I think also, even just reassuring them that you're going to give them the information you're telling them. And so they don't have to focus on remembering every aspect. And I think often for trainees, when you're trying to, you have a patient, you're trying to, give them a new diagnosis or counsel them about different treatment options, it's really hard because you're trying to get across all the information while also respecting the place that patient is in and making the decision. And, using handouts and saying to them, I'm going to walk you through this. You don't even have to make a decision now. I'm going to have all this written down for you to take home with you, and we can have another visit to come back when you've had time to digest, talk with your family, talk with other people, whatever makes sense for you. Letting them know that that's an okay trajectory and what's coming can be helpful. And it takes the pressure off you as a provider also, because now you're not trying to get through the whole deal in this one, 20-minute visit that you also, by the way, have to document, right?
Yeah, I think that dispels a lot of myths of having all the answers and tying it up and, having to talk to avoid awkward silences or checking that box at the end of your visit. So these are things that can be left incomplete. And I think that those are really important things to bring up. What are other specific metrics that people should keep in mind when assessing the impact of this intervention on someone's outcomes? And anything specific to urology, postoperative care, something like that? Are there anything that you can share that would really convey the impact of the intervention?
Yeah, palliative care is being integrated into many different scenarios, and so I think there's been a lot of interest in figuring out the impact of palliative care on particular, types of cancer or other serious illnesses. The way I kind of think about it is some of what palliative care brings to the table is hard to quantify. It's really hard to quantify having a good conversation around, what treatments to pursue or helping someone process emotionally the challenges of going through a serious illness. So I take a lot of the studies around impact of palliative care with a little bit of a grain of salt. Having said that, a lot of the reason why palliative care has expanded in so many hospital systems is because it tends to help people manage their symptoms better, meaning, lower pain, higher quality of life in general, addressing things like fatigue, nausea, mental health challenges like depression, anxiety, and poor sleep. From a hospital system standpoint, it tends to lead to more cost-effective care, meaning shorter hospital stays, fewer readmissions, and fewer complications after these conditions. And then a third metric is advanced care planning, kind of having conversations around what people want and aligning treatment options with those values. Now, there is some controversy around advanced care planning. I think in some recent years, it was really seen as like a checkbox metric where, I've got my advanced directive done, boom, we're done. Instead of it being an ongoing conversation where people's goals naturally evolve as they might experience changes with their serious illness. So I think we're being careful with advanced care planning just being a metric versus a process. And I think that's relevant when we're thinking about impact.
Ashwin, what do you think about like end of life healthcare utilization as like a proxy for palliative care outcomes? Is that something that tends to kind of flow one into the other, or are there not much correlations between the two, like involvement of palliative care and end of life utilization?
Yeah, great question. There is a lot of discussion around the types of healthcare use at the end of life that might signify like a good death, right? That maybe that involves people being out of the ICU, dying at home with hospice, not undergoing intensive medical therapies. I think the reality is it's different from person to person. Some people actually do want to have a really aggressive therapy, up until the last moments of their life. I think about many of our patients who have sudden, diagnoses of really aggressive cancers and are kind of still processing a lot of that shock and undergoing really profound treatments up until those last moments. So, you can kind of see the full spectrum of what's appropriate versus not, and it depends on the person. So I think when we're thinking about how to provide treatment recommendations and how to actually achieve what we call goal concordant care, I really think about needing to know two things, two key elements before you can understand if what you're providing is goal concordant or not. The first is, what are their values? And that might be, you share serious news with someone and you ask them, in light of this, what are you hoping for? Or what are you worried about? What's really important to you? How do you spend your day? And getting a sense of values can get a sense of, what the end goal of potential treatments would be. The second key element to think about is, what is a person's prognosis? In the best case scenario, in the worst case scenario, with the various treatment options, because that can help get a sense of what is actually a feasible goal that we can try to achieve here. And once you have those two elements, better figured out, then you can start thinking through what the treatment options are that best align with a person's values in light of the likely prognosis. Doing that, I think, is much better than just thinking about kind of these metrics that people have around healthcare use at the end of life that don't really take into account all of those, patient-centric factors.
I think that's incredible. And so valuable, even just the understanding of how to ask people what matters to them. Because at the end of the day, that's what really matters. And we don't even know how to do that well. So when we think about our training, is probably like a big aspect of our training that we need to improve. It's just how to understand what people's goals are. Because like Pauline, you're talking to cancer patients, but I'm talking to patients with incontinence, and what matters to them still impacts what, decisions they're making, even with regards to their treatment of incontinence. So like every medical decision they're making, really, especially the ones that, have big impacts on quality of life, which many urology conditions do, it's so important to understand that. This has been such a fantastic dialogue and hopefully a start of infusing some excitement in our trainees of, learning more about getting more training in and more comfortable around goals of care conversations in palliative care. I love to end by giving each of you a moment to any last minute tips, tricks, pearls, takeaways that you think it's important for a urology resident to know. Pauline, we'll start with you.
Yeah, this has been just awesome, and I'm so glad you guys are doing this and making this kind of topic something that urology residents will have, a nice hour intro to a little bit. I think something that I didn't know is that for people who are really excited about palliative care delivery and want to get much more into it, you can enter a palliative care fellowship from any field. So if you're a urology resident wanting to specialize in palliative care delivery, you can do a palliative care fellowship, which is a year-long program. So I think that's something to keep in mind. I think there's also, it's a really kind of newer research field within urology. I think there's a lot of people excited about potentially seeing the impact of what palliative care can do when it is integrated in our urologic care, but it hasn't really been studied at all, very much at all. So I think trainees interested in doing this work and if in bringing the work to our field would have a treasure trove of opportunity. And I think thank you for listening, I guess.
Ashwin?
Yeah, I think my one takeaway I would suggest for trainees or residents is to approach serious illness communication. So when you're having a difficult conversation with a lot of intentionality. So, really, I've worked with surgeons, to Pauline's point, there's a lot of surgeons in the palliative care field. And one thing they've told me about is that they approach these conversations or family meetings just like they would the OR, with a lot of focus, preparation, and really being in the moment. And I think that's the same thing here is to really be intentional about these conversations. And it can be helpful sometimes to have a communication framework in your back pocket to kind of work through and practice. So I would peruse some of these resources that we mentioned, a few other nice resources. There's a New England Journal procedure video on serious illness communication on family meetings that people can watch, and they have a nice communication framework there. The Vital Talk website has a lot of really nice videos and communication frameworks there. So just find one, and practice it a couple times, make it your own, make those words your own. I think that can go a long way.
Even writing it out sometimes can be helpful. Like you said, preparing as if you were preparing to go into a surgery, sometimes involves writing out a sentence of how you would deliver a diagnosis. Because sometimes the words, don't naturally come to you. But I think having intentionality behind it makes it much more effective. So it's a great idea.
It's great. Those are great pearls of wisdom to end on. And we really appreciate both of your time and your expertise and your insights. And we hope, as you mentioned, that this touches both our resident audience or anyone within our field who's looking to learn more and incorporate these important practices into their clinical activity. So thank you both so much.
Yeah,
Thanks
it was
for
great
having
to
us.
have you both. Love having the perspective, and I'm just seeing opportunities for collaboration here.
Absolutely. So many opportunities for collaboration. And yeah, thank you so much for having us.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.